Hello, everyone. This is Dr. Divyam Goswami, and along with my colleague, Dr. Bhavya Bansali, we are arranging the DiGo Talks on psychodynamics in our day to day professional lives. And our guest speaker is Dr. Himanshu Agrawal from United States. And Dr. Himanshu, can you introduce yourself?
Absolutely. Hi. First of all, thank you for having me here. And one point of semi-protest, semi-clarity. It's Dr. Himanshu Agrawal from India, practicing in the United States. So, but and I actually just recently wrote a paper about it from, going from Asian American to American Asian. But, I absolutely, I'm a citizen of both places, and my heart lives in both places. And so, like you said, Dr. Divyam, I'm a I let me tell you a little bit about everyone about myself. Otherwise, they'll think who's this guy on the screen. So I was born and raised and brought up in New Delhi. That was base camp, and I had the pleasure of traveling to different countries in my childhood. London, Moscow, but those are cities, Nepal, and Bangladesh. And I went to medical college, or as they call it in USA, medical school, at a place called Maulana Azad Medical College in New Delhi. And after that, I emigrated to the United States to pursue my residency in psychiatry. So I did 4 years of that. And then after that, I did 2 years of fellowship in child psychiatry. So I'm a child psychiatrist. And then I went back to get trained to be a psychoanalyst, which took an extra 8 years. And um, I've recently finished a term in academia. I was an associate professor at the Medical College of Wisconsin, and right now I'm in private practice. But as they say, you can leave academia, but academia doesn't leave you. So I am so glad that I still have the passion to teach and, more importantly, learn from my colleagues. So thank you. This is brilliant.
Yeah. Thank you, Dr. Himanshu, for introducing yourself. And now I think we can start the presentation.
Absolutely. Right. So, want to thank DiGo Community Talks again for arranging this platform. And I'm really excited to see what questions or comments, not just the two of you, but also what the audience of this webinar will have um, on an ongoing basis. So, let me start by announcing the not so hidden agenda. Right. So, I'm revealing my unconscious here and saying this, I'm perfectly aware of my agenda here. And so what we'll do today, hopefully, in the next hour or so, is a quick overview of what psychodynamics actually means. The word is thrown out a lot, and it means something different to everyone, but I'll try and share what it means to me. We'll introduce the concept of the developmental arc of childhood and how it matters in your day-to-day professional life. And this is, when I say professional life, I believe it's pertinent to any person that has a job, whether they're like a low division clerk in the Indian government, or an ECT specialist in London, or if they're president of the United States, and so on and so forth. So anyone that is engaged in any kind of professional endeavor, uh, my goal today will be to introduce the concept of psychodynamics and how you can use it, you can harness it in your day-to-day life. For example, we'll be talking about introducing the concept of the unconscious that Freud made up, and how you can use that concept in your day-to-day life and how it shows up. We'll do the same thing with transference and countertransference. All of these are, you may or may not know these terms. That's okay. We'll talk about it in detail. The observing ego and then defense mechanisms. But so it's a lot to cover, but hopefully it'll be just kind of a slice, a little snack of all of these different things in the huge ocean of psychodynamics. Does that sound good, sir? I think Devin went on good. So I'm going to zoom that we're good to go. Okay, so first things first, the word psychodynamics. Um, it comes from Greek origin, and the first part is psycho. And of course, there's a lot of memes and jokes about that, but really, psycho comes from the Greek word psyche, which actually means soul or mind. Um, And so that's one of the big disservices that has happened to us psychiatrists, where we have been called doctors of the mind or the brain. But really, the way that Freud meant it when he came up with psychiatry and psychoanalysis was soul. And I do believe that treating the soul or serving the soul has a different meaning and feeling than serving the brain. And the second part of that word is dynamics, which comes from the Greek dynamikos, which itself is derived from the word dynamis, which means a force or an energy. So that right there on the side is actually is from Greek mythology. That's psyche that represents the soul. And there's a beautiful story of the Psyche and Cupid, but that's neither here nor there. We won't go there. Um, but the way that I like to think of psychodynamics and the way that I would like to present it today is that psychodynamics is basically the continuous study of an invisible, ever-changing energy as it travels from one mind to another. In other words, psychodynamics assumes that there's something going on, some kind of an energy or a force between every single mind, and observing what's going on between two minds and how it affects life and what we can use from it to help in our life is psychodynamics. And dynamics also means that it's constantly changing. Just being aware of that and thinking that way, I would say, is the psychodynamic way of living. It's really more of a lifestyle than just an academic or scholarly um, book on a shelf. So really, the world of psychodynamics kind of did it topsy-turvy. So Sigmund Freud, over 100 years ago, invented this thing called psychoanalysis. And that was very, very intense kind of therapy. And so it's like we developed the PhD program before we developed the bachelor's or the master's program. I mean, that's not a completely accurate analogy, but really we started with the hardcore 5 times a week, laying down on the couch stuff. And then over time, over the next 100 years, it became more and more relatable, more and more accessible, and less elitist, less cost prohibitive, and evolved into what we call psychodynamic psychotherapy. But along the way, there were several different people that came up with several different theories, or as we say, schools of psychoanalysis. Freud started with his own stuff, and that's called Freudian analysis or classical analysis. And then his daughter created a new school. Anna Freud created a school called ego psychology, a way of thinking. And then there were Melanie Klein came in, and there was a big rift, and which led to this middle school, the British middle school. And later on, there was another rift when self-psychology came in by Heinz Kohut in the 70s. And then recently, there's been another rift of controversies with the relational theory. What I'm trying to say is this. One thing that is stood the test of time is that every time some new thought is brought into the world of psychoanalysis, there's a fight that starts. Everyone is fighting with everyone. It kind of reminds me of small kids, really, that are fighting on a playground saying, my dad can beat up your dad. It's very unpsychoanalytic when you think about it, but that's the irony that it exists right in the middle of a so-called evolved science. And I recently graduated from psychoanalytic training, but when I was a student, they're called candidates. Especially when I go to the meetings, the national meetings of the illustrious and very prestigious American Psychoanalytic Association that used to be like the Waldorf Astoria. Sometimes it felt like we were like little kids trying to intervene between mom and dad as they're shouting at each other that I'm better than you and you're the better than me, when we would see these stalwarts fighting with each other. So hopefully I'm saying this because hopefully it debunks some of the romanticization and unnecessary idolization that often accompanies the word psychoanalysis or psychoanalyst. They are quite human. And it's true that to become a psychoanalyst, you have to go through rigorous training. So you need to have some strengths, you need to have a fair amount of intelligence, fair amount of emotional intelligence, you need to have patience, you need to have fortitude. But I also believe that we forget the other half, that most people that end up wanting to be psychoanalysts, something really traumatic happened in their childhood. Otherwise, why would they want to pursue this very, very difficult way of getting help? Um, if their childhood wasn't a little troubled, then they would have gotten better with just psychodynamic or CBT or supportive therapy. So we often forget that these are also troubled neurotic souls. So hopefully that's one myth we can bust today, is that psychoanalysts are perfect, or they really know everything. The only thing that I've learned through my psychoanalytic experience is that I know nothing, and I'm open to learning more and more. Hopefully that wasn't too vague or cryptic. But there's three things that all these schools that keep fighting with each other over differences, there's three things, fundamental things that they can all agree with that brings them together. And those three things are these. First thing, everyone, each one of these different bends or schools believes and agrees that childhood matters, which is a big deviation from the protocol and the techniques used in CBT, where, of course, they're not saying childhood doesn't matter, but they focus more on the here and now. We don't talk too much about childhood in CBT, and I practice CBT also, and have great admiration for it. So please, at no point should this feel like it's saying that CBT is better or psychodynamics or psychoanalysis is better. They're all have their own place. But CBT talks about the here and now. Psychodynamics tends to delve into childhood and how childhood experience, formative experiences, are showing up and affecting how you're behaving right now, and how those behaviors are coming in the way of living a good life. The second thing that everyone agrees on, that there is something called the unconscious. They might have different ways to look at it, but everyone agrees there's something called the unconscious, which was a new concept, a very novel concept that Freud developed in the early 1900s, late 1800s, and it was so revolutionary that people have called it the third big revolution of humanity. So the first revolution was when Galileo said, we're not the center of the universe. The second revolution was Darwin, when he came up with this theory of evolution. And the third revolution was the unconscious. So clearly it had profound effects on the entire world. Now, it wasn't perfect, but it was important. And I think we need to keep that in mind as we look at it and critique it. The third thing that everyone agrees with is that there is something called transference and countertransference, and we'll get to that in a little bit. And these two concepts really help um, progress or push the therapy forward and reach our goals. And we will talk about all of these in a little bit more detail now. So the first concept is that childhood matters. This is how I think it is applicable to all of you in your day-to-day lives. Okay, I'm going to speak to people that see patients, but then please substitute patients with clients, or whatever you want. So, but I want all of you right now to think about a client or a patient that you don't like. I'm sure you all have one, and of course it'd be unprofessional to say it out loud. But I know that everyone has that. Let's say if I'm a physician or a therapist, and I see my schedule for today or my schedule for today, and I look at a name like, oh man, they're coming. Oh geez. Oh well. And then there's others that your face brightens up. So I want you to, maybe if you need to close your eyes, but think about someone that you just can't stand. Hopefully you're thinking of someone. Now, this is how the developmental arc might help you in your day-to-day life. I want you to think about a timeline. I want you to think about this person and their timeline. So even before they were born, even when they were just a glimmer in their parents' eyes, there were genes at work. These folks were predisposed, vulnerable to certain conditions like high blood pressure or bipolar disorder or alcoholism or even personality disorders to an extent. So even before they were conceived, they had stuff going on against them. Um, let's say this person was, when their mother was pregnant with them, their father was smoking cigarettes, so they were exposed to secondhand smoke. Or let's say that the mother was the victim of domestic violence, and someone hit her in the abdomen, and she was just continuously flooded with cortisol. And that can't be good for the developing baby. So even before this kid is born, there's things that are working against them. Now, let's say that they were born prematurely and they had to spend 2 months in the neonatal ICU unit. And let's say as they were being transported back or given back to their parents, the nurse, their hand slipped, they fell down on the ground, they had a traumatic brain injury, which affected their personality and their mood forever. And this poor person then went on to develop juvenile diabetes and then also even developed seizures, epilepsy, because they have the genetic predisposition. So even before they're teenagers, all of this is happening. And now let's say as they're growing up, they were the victims of physical or sexual abuse, or severe neglect, where they had to take care of themselves while their parents were busy working and they were home alone and making their own meals, et cetera, et cetera. And let's say they found illegal drugs, um, uh, either alcohol or ganja or over here opioids that are a huge problem in the USA. Now this person has not even become an adult yet, and look at everything that is stacked up against them. And let's say right before they came to see you as a patient, they had a breakup with their significant other, the boyfriend, the girlfriend, and because they were living with them, because it was a live-in relationship, now they're homeless. They have no place to go. So this is the person that is showing up at your door. Now close your eyes and think honestly. Do you still see this person the same way that you did a little while ago? So if you think of every single person, even if you take the next time you're about to see a patient or a client or take a meeting, next time you're about to enter a room with your boss that you don't like, just close your eyes and for 1 or 2 seconds, it doesn't take too long, think about this developmental arc. You don't have to go in detail about what might have happened, but just the fact that all of these things have happened to them right before you met them might really change kind of your state of mind and your attitude as you walk in. And I would posit that this can really make a difference in going from judgment to curiosity, going from burnout to thriving, especially if you practice it over and over again. And it doesn't take that long. Now, I forgot to say that during this talk, I'm going to be making 3 shameless plugs, right? So, and the first one is about to come up, and by which I mean shameless advertising for my own institute, the Pangea Institute. So, I finished my 4 years of residency, psychiatry residency, and at the end of it, I really wasn't an expert on anything except psychopathology, I feel, and that too within adults. And it was only after I did my 2 years of child psychiatry fellowship, and I'm just speaking for myself. I'm sure there's people that are much more brilliant and much more emotionally nuanced than me that were already there. But it took me 2 years, extra years, seeing children after children after children to realize, oh my God, there's so much that I've missed. And it made me want to go back to my adult patients, especially my therapy patients. And it made me think about how my entire approach would be different now that I was conceptualizing them at having this whole arc. The questions I would ask, where I would pause, where I would listen, where I would hesitate. And so, this is the shameless plug. So I ended up writing this piece for academic psychiatry. And even though most of my patients are adults right now, I think that um, I have been lucky enough to get mentors and the guidance where I never see an adult. I no longer see any adults. I only see children who have grown up, and in some cases haven't. So if your primary patient or client population is adults, consider just thinking that all of them had a childhood, and consider looking them as children that have grown up and everything that's happened for them. So my hope is, and my guess is, in fact, I'm willing to bet that if you can incorporate this into your daily life, you will never see an adult again, just children that have grown up. And in some cases, haven't. Um, as you, since this is a webinar and we're going to keep questions for the end, I will keep proceeding. Um, let's next talk about the concept of the unconscious. So this came up or circa 1900. There's some debate about when Freud actually thought up about this model, but this is the original model he came up with. Um, it's in German and it's a little archaic. So this is the modern interpretation of it. So basically, what Freud was saying is this: is that our mind, not our brain, our mind is stratified, divided into three sections. And he made the comparison to an iceberg. As you may know, iceberg, only 1/9 of the iceberg is above water, and 8/9 of the iceberg is always underwater. So he said, the part of our mind that's above the water that we can be aware of, that people can be aware of, is called the conscious. And that's where CBT operates mostly. The CBT also operates at what we call the subconscious level or the pre-conscious level. Now, what is the pre-conscious? Um, it's when we say, "Oh, what's the name of that song?" It's right on the tip of my tongue. Oh yeah, yeah, that's the song. So things that we don't remember clearly, but what we can recall with a little bit of effort, that's a pre-conscious. And I'll be making some Bollywood references today because I'm a huge fan of Bollywood. And if you're talking about things you love, then it doesn't feel like work. But please feel free to insert your own examples. And people that are not familiar with Bollywood, you're missing out. But I'll try my best to explain what I'm saying. The third and the largest part of our mind is what Freud called the unconscious. And fundamentally, by definition, it is hidden. We are not aware of it. If we are aware of it, we have somehow brought it from the unconscious to the conscious. And that's a very powerful technique that psychodynamic psychotherapists use, is slowly, carefully, with the right speed and right pace, and the patient gets to decide the pace, not us. We try and bring some things from the unconscious up to the conscious, and that can change lives. But most of what we're doing every day is actually being driven by the unconscious, and we don't realize this. That's the theory. I'll give an example. When I teach defense mechanisms to my medical students, I tell them that we are a civilized society, quote unquote civilized society, and we're following all these societal norms. And so if they're going out on a date, right, a lot of them are in their 20s, they're going on their first dates. Um, everyone is trying to impress you on their first date. So you don't really know who the real person is inside. Um, so what I say to them is observe them when they're in the car. If they're driving the car and you're with them, the first thing I say is, why did you get in someone's car on a first date? Right? So because I'm paternal that way. I've become a father and I kind of scold them. But what I say is that's where you'll see who he or she really is. On social media and in cars, somehow we have this illusion of invisibility. So someone that is so polite and so deferential suddenly turns into rageful, swearing, yelling person in the car, honking at other cars. And it gets embarrassing when the person you honked at turns out to be a boss, because you would never do that in the meeting. And so my one of my favorite movies is Lage Raho Munna Bhai, which is the context is this, the setup is that this is Sanjay Dutt, who's the guy in green. He's on a radio show and he's giving life advice. And there's a girl that calls in and she says, I my parents want me to marry this guy. It's an arranged marriage, and I'm going to meet him for the first time, and I have to decide just in one meeting. How can I know who he actually is? Because he's going to be trying to impress me. So what Sanjay Dutt says is, observe how he's talking to the server, to the waiter. That's the real him. So the guy comes in, all prim and proper, all polished. He's courteous. He like puts the chair for her, and he's a complete gentleman. And he says, "What would you like to drink? It's so nice, such lovely weather." And then he goes, "Hey, come here." He talks like a complete jerk to the server, and that's who he is inside. And so, since it's a Bollywood movie, she ditches him and she says, "Thank you, you saved my life." But that's an oversimplified example of what of the unconscious at work. How could this show up in your life? This is not an exhaustive list at all, but the unconscious might be at play if you find yourself speaking more formally with some patients and more casually with others, or if you are offering more detailed explanations to clients who you perceive as educated or affluent compared to people that you don't. Or you might find yourself day to day when you're talking to people interrupting certain people more quickly than others, and so on and so forth. So here's some homework for you, or here's my something to consider a suggestion. The next time you are aware of your unconscious, um, go like this, ding ding. If you think that something unconscious has happened, just say to yourself, ding ding, and then observe how many times you're pressing the bell icon, so to speak, but in real life. Um, you'd be surprised at how often the unconscious is at play. And now that I've talked about it, as they say in the first page of Love and Bailey, the surgery book, the eyes do not see what the mind does not know. So now that you know about this concept of unconscious, you'll be fascinated at how many times you're ringing that bell in your head. Just a quick demonstration of the power of the unconscious. So that those are my thoughts on the unconscious. Um, the way that CBT, cognitive behavioral therapy, approaches the unconscious, conscious, and preconscious is, as you know, this is the world famous Beck's triad. That thoughts affect behavior, behavior affect feelings, feelings affect thoughts, and vice versa. So it's a bidirectional arrow. And this model has helped millions of people in the world. I have great respect for it. And it tends to go in a certain pattern. And it tends to generally stay at the conscious and preconscious levels. However, psychodynamic psychotherapy, especially intensive one, it doesn't have a set pattern. So, if we see this as a sea and we're exploring the iceberg, we might take a dive, and then one day we're swimming to the right and to the left, and we're coming up again, and we're coming down again. It's all over the place, or it might seem so. It's a lot more freer. I will assure you there is a method behind the madness. There's actually a lot of technique, framework, and standardization within the world of psychodynamic psychotherapy. It's just that I believe this is, again, just my opinion, that as a faculty, as a group, we really are not very good at explaining this standard or this process. We're very good at doing it, but for some reason, they don't teach us how to explain that this is going to be how to do psychodynamic psychotherapy and what to look for in different phases. Here comes the second shameless plug. That was an unconscious slip. If you're interested in knowing more about the different phases of psychodynamic treatment and how that can help with your patient, um, uh, I'm teaching this live and virtual online and you can find more details at the Panja Institute for Psychodynamics. Um, so that's a little bit about the unconscious. Um, the, the next thing that we want to introduce is something called transference and countertransference. There's a lot that is written about this, and especially about transference. The concept of countertransference did not even emerge in the literature until the 1950s. Those are 50 years of just talking about transference. What is transference? Transference basically, and again at the risk of oversimplifying, is whatever feelings our patients feel about us. Whatever they're feeling about us, whether it's valid, whether it's perceived, whether it's fantasized, imagined, that's transference. And countertransference is whatever we feel about our patient, all of that collection of feelings. And of course, thoughts and behaviors are constantly interacting with those feelings. You'll notice this word transference. It's from the world of electrical engineering. So is resistance. So a lot of the words that psychodynamics theorists and clinicians use sound like something that an electrical engineer would use or an electrician. And that's because when these concepts were formed, Freud was a neurologist. And at that time, a clinical neurologist, when they practiced, it looked a lot like what electricians look like today, or electrical engineers. And unfortunately, like so many other things, we're still sticking to some of these terms and refusing. Maybe we're in denial that it's 2026 and maybe it's time to look at things a bit differently. But I don't appreciate that words like transference, countertransference, they create confusion because it means something completely different in today's day and age. Oh well. Um, Many of my teachers talk about countertransference and transference as an ongoing seesaw. Uh, and it's a constant balancing act. So for every transference, there's a countertransference, and like Newton's third law. However, um, the teachers, my favorite teachers, actually uh, invite me to imagine, and I invite you to imagine, transference and countertransference between us and our patients, our clients, is more like an elegant and very sophisticated dance. And I put that illustration there on purpose because, as you can see, there's some erotic, sensual components to that illustration. There's this intimacy, including maybe some sexual tension. And that can be a very common part of our transference and countertransference, whether we wish to accept it or not. So it's there. Many of our patients and clients feel very strong feelings towards us, negative, but also, in the area of attraction, and oftentimes they might confuse their own feelings of adoration or affection or respect as attraction, and vice versa. Um, and I think psychodynamic psychotherapists, uh, uh, generally speaking, are encouraged to think about how to be aware of that, but also how to harness it. So it can get very tricky, but it can be done. And again, just a reminder: if you would like to know how to be done, how this can be done, especially in the middle phase, just contact us on the website. I'm not calling this my um, uh, third shameless plug because it's a repetition of the second one. So there. Um, how does countertransference look like in your day-to-day life? Let's do a practical exercise. Again, I want you to think about your most unlikable patient or client, maybe the same one that you did for exercise one, or maybe someone different. The patients or the clients or the people that we interact with every day, they tend to be generally belong to four categories, and there might be more, but this is what I've seen in my experience. There's the needy patients or the needy clients that just cling and just harass you nonstop and call you nonstop and say they can't live without you in one way or the other. There's the entitled patients that think that they deserve special service. These are the ones that say, I've been waiting for 10 minutes and he hasn't come and seen me or she hasn't come and seen me, and I'm important, so I need to get to the front of the line. They can evoke very strong feelings within us. There's the angry patients, people that just come and yell at you and they say you're incompetent and you can't do anything right. And of course, there's the passive aggressive anger where they might say, Doctor Saab, you're so wonderful. You're so amazing. You're so talented. So I'm so surprised that you haven't been able to fix me. Or they might use displacement. I think you're amazing, but my mother was saying that he's an idiot. So I don't know what to do with that. So that's the angry patients. And of course, there's the disorganized, scattered patients. These are the patients that are always running late, that don't remember what meds they're on, or didn't remember to do their CBT homework. And you feel like you're having to hold all of that disorganization within yourself. So these are just four of the most common unlikable people I've met in my life, right? And of course, you might have some other thoughts, but I want you to think about a patient that reminds you of one of these profiles. And think about how you feel about them generally, the worst that you felt about them, the most negative thoughts. You don't have to say it out loud. You don't have to put it in the chat, but the most negative that you felt. My guess is that many of you are thinking that you want to hit this patient, slap them, tell them to get out. Of course, you wouldn't do it because it's unprofessional. Or that, for the entitled people, you want to show them their places. Like, you know what? You're not special. You know how long people wait to see me? Get back in line. Or the needy, you might say, just get away from me. Go somewhere else. I'll refer you to someone else. And the disorganized, you might feel like, come on, why can't you just get your stuff together? Um, so hopefully you're really swimming in the soup of negative countertransference right now, where you can feel those emotions as they're, maybe you can feel your blood pressure rise and your heartbeat rise as you're thinking about these patients or people in your life. Now, I want you to think about your favorite person, your favorite patient, the most adorable client you have, someone where you think about them and it brings a smile to your face. And I know that everyone has one. For me, that person is Shah Rukh Khan, the old Shah Rukh Khan. the young Shah Rukh Khan. He's the epitome of charm and adorableness to me, so I'm going to use him. Um, you know, so people like that might evoke a very different kind of countertransfer. Oh, too sweet, or oh my God, they're so wonderful. They're such a human beings. Oh, I wish all my patients were like that. I can't wait till they come back. Um, or you might find them good looking, and as shallow as that might sound, it might be like, oh yeah, that's nice. I'm looking forward to seeing them. These are all human emotions, which we cannot deny, but identifying and acknowledging them does not mean that we're going to act out on them. Thinking something, feeling something is very different than doing it. Um, that's another thing that psychodynamics tries to underscore. Now, here's what I want you to do. This is what I do every day, day in and day out. Every single patient I see, every single colleague I interact with, I would like to recommend that anytime you are about to interact or interacting with an extremely unlikable person, close your eyes if you need to, or if you don't need to close your eyes. Imagine, take their face, take their personality, and then substitute it with the most adorable or your favorite person. And then think to yourself, this medication I'm about to prescribe. This follow up, when I'm saying follow up in 6 months as opposed to 6 weeks, or if I'm referring them to a certain therapist, would I have done that the same thing for my favorite patient? And vice versa. If you've got someone that you're just, oh man, I love you so much. This is so great. You're such an excellent patient. Here, take this medication. Now substitute that person with the most unlikable patient you have and think to yourself, would I be making the same recommendation for that person? And you will often see that we have a tendency to shortchange the patients we don't like and overextend ourselves to patients that we do like. And that can also sometimes be a problem. I'm way more likely to give, a prescription of sedatives or tranquilizers or, to Shah Rukh Khan than I am to someone that's super needy or super entitled, because I'm human. So it's a constant battle. It's a constant tussle, a constant dance to be aware of your countertransference. And I believe that if you're aware of your countertransference, um, eventually, oftentimes, not always, but oftentimes you can harness it. You can abolish it, but you can harness it to make sure that you're providing equitable care, equanimity, the same amount of professional care or similar kind of professional care, irrespective of how you feel about the patient. So in our day-to-day life, we call this professionalism. But to me, professionalism is nothing more than constantly being aware of your countertransference and uh, letting that guide your decisions and your views. And if your countertransference runs amok, if it's out of control, well, that's where the bad doctors come from. This is from Kabir Singh, which is the story of a very um, um, ill-disciplined and unprofessional surgeon. And he does it all. Everything you can think of when you think of unprofessionalism, he does that. And I would say that fundamentally, he's someone that is completely unhinged and does not care about his countertransference. He just does whatever he wants. So that can be the difference between a very successful and well-liked professional and someone that is miserable and falls short of their potential. And here, I would like to say is the OG, the original place that I have found this whole concept of equanimity. It's amazing when you read the Gita, and I'm not trying to proselytize any particular religion. I'm just saying this is where I've read the Bible too, and read the Quran, and I feel like this is what really sums it up the best. Is when Krishna is talking to Arjun and talking about treating everyone with equanimity. It really is brilliant. So Freud might have brought some things to the world, but definitely wasn't an original thought. Um, the next concept I want to talk about is called the observing ego. What is the observing ego? It's a psychodynamic term. And please look at this picture. Let's say that this is a therapist in a session with their client. or a doctor in a session with their patient that wants to go through surgery or whatever. And you know, the person on the left, the doctor or the therapist or the professional, is is observing their patient or their client, and maybe they have some thoughts. So maybe their thoughts are like, look at how she's sitting. Why is she so casual in a formal session? I must be careful about setting boundaries. We all have those patients that are a little too lackadaisical, sit too closely. And so maybe that's an example of what she's thinking. Now, what psychodynamics says is um, try and bolster the power of your observing ego. And what is the observing ego? Imagine that you are observing your patient and what's going on, and maybe to a certain extent observing yourself. But observing ego takes it to a whole different level. Imagine there's also you in the same room, hovering above both you and the patient, and taking in the entire scene, kind of like a director, a movie director that's like directing and looking at how everyone's doing. So that is the observing ego. And if you can practice and make your observing ego stronger, maybe, the observing ego will look something like this. Now, this observing ego is looking at the entire scene. And maybe they're saying something like, look at how I am sitting as I look at how she is sitting. Why am I so stiff during this session? I must remain aware of my anxiety about maintaining boundaries. So you see, it's perfectly uh, important, legitimate, and professional for us to be aware that, oh, that person is sitting too casually. I need to be aware of maybe maintaining boundaries. But psychodynamics takes it one level higher. It's thinking about thinking, feeling about feeling. So even as I am legitimately thinking about a strategy to make sure that boundaries are not violated, this observing ego is saying, oh, Himanshu, wait a minute. I must also point out that you're feeling a little anxious, and because of that, you're sitting more stiffly than usual. And there's nothing right or wrong about that. Just be aware of it. And the observing ego can really add to our not just our diagnostic potential, how good we are at diagnosing things, but also in building alliance and bolstering compliance. People with observing egos, strong observing egos, their patients do better because they're catching more things because the eyes do not see what the mind does not know. Uh, So I know I'm throwing a lot at you, but maybe there's a lot to cover, and if you have any questions, feel free to put them in the chat, and I'll do my best to answer them. Again, the concept of observing ego. You can see not just traces, but actually very direct references of the concept in the Bhagavad Gita. And that's where I feel like, especially if you're in a country which has a lot of Hindus, we can really harness the power of people who are big fans uh, of sacred texts to bring forth or to simplify uh, or operationalize our psychotherapy interventions and recommendations, and the same thing with the other religions too. A quick word on the world of the vast world of defense mechanisms. So what are defense mechanisms? Defense mechanisms are everything we say or do to make something that is anxiety provoking or distressful a little bit less anxiety provoking or distressful. It doesn't have to be that it becomes completely distressless or no anxiety at all, but something that's more anxiety provoking to a little less anxiety provoking. So people that use very, very immature defense mechanisms, let's say someone has anger problems and every time that they get anxious, they hit someone. It makes sense to think that actually even that is probably better than what they were initially thinking. There could have been something worse. Maybe they were thinking of stabbing you. So they've used defense mechanisms to bring it down a little bit. And so it's all relative. But one of the most practical defense mechanisms that I use on a day-to-day basis, and I'm hoping that you will consider using it too, is what Freud called regression. Regression is a defense mechanism where someone is actually because of duress, because of anxiety, most common reason is anxiety. they go back in time developmentally. So they start acting, behaving like a much younger person. I want you to think about what happens to us, especially men. And I'm sorry, I'm not trying to be sexist here, but at least in USA, there's this whole notion of the man cold. So when we get a common cold, when we get a viral infection, men become babies, and we want to be taken care of, and we're like, oh, well, I want soup. Oh my God, I can't work at all, and and there's different standards for women, um, where they still are expected to show up to work, et cetera, et cetera. And so that is regression because they're actually acting like small children. So one thing that I want you to think about anytime that you're getting annoyed by a patient or a client, um, don't think about how old is this person right now. Consider thinking, how old is this person behaving right now? And how would you approach someone that is behaving that age? Um, and for this exercise, I'm going to use the example of one of the most famous people in India, if not the world, Mr. Amitabh Bachchan, who's a big Bollywood superstar. So let's think about it this way. Let's look at the characters he's played across three movies. So in this movie, Diwar, he's an angry young man who has a lot of angst and a lot of recklessness. What age are we usually when we are normally like this? So think about, is there a time in our life, in our developmental trajectory, when we are full of angst and full of pathos and pain and tend to be reckless? Hopefully you will agree that that reminds me of a teenager. Um, Most teenagers go through this, where they're going through the world does not understand me, and they do some pretty silly stuff without thinking it through. I've done my share. And so if this man was coming to you as a patient, then it would make no sense to talk to him like he's in his 30s. It would make sense to understand him as someone that's basically acting like a teenager. And then what would you say to a teenager? And what I tend to say to my teenagers, what really works with them is I really validate them. I validate the heck out of them. Uh, I, I I take like a cool approach, like, oh yeah, you're right. Your angst is absolutely valid, and yeah, the world doesn't understand you, and I don't understand you either. So please help me learn, bro. And then that helps with the alliance, and then where it goes forward, as opposed to if you take an authoritarian stance. Um, Next, let's look at the movie Abhiman. Same guy playing a different character. He's a very renowned singer in this movie, and then he marries someone who is an even better singer than him, and she ends up overshadowing him, and she gets all the limelight. And Abhiman means arrogance or sense of superiority, um, ego. And so when you think about Amitabh Bachchan, who is struggling with someone that is better than him, that is getting all the attention, is there an age where we're more likely to go through that? Of course, even as adults, we go through that, but there's a fundamental age where it is very common for people to go through that. So this reminds me of, let's say, a 6-year-old, and they've just had a sibling born. They've got a younger brother, a younger sister. They were the apple of their parents' eyes. The whole family just absolutely loved them. They had undivided attention. And now suddenly this little kid has come along and is getting all the attention. And the envy and the rage that is filled in that kid and the confusion. Now, if that guy came to you as an adult, it would make no sense to say, why are you acting like a kid? You're 35 years old. Grow up. If you try and understand that he's acting like a 6-year-old, what would you say to a 6-year-old? When my brother was born, I was 5. I was devastated. We're best friends now, but man, I had some pretty aggressive thoughts when he was born. And a good parent comes to you and says, I know it's not fair, is it? But you know what? There's plenty of room for both of you. There's so much sunlight, so much love in the world. And um, this is what you have to do. This is what you have to offer. And look at this kid. He's going to look up to you, and you'll be his boss. Well, we'll be his boss, but you can show him how it's done. So really use their ego as a bootstrap to attack the ego. Last but not least, There's a movie called Majboor, where Amitabh Bachchan, who has a disabled mother and an unwed sister, and he's got all the responsibility of the family. He's the man of the house. He develops a brain tumor. So he goes through this very poignant. Well, it's a Bollywood plot. I won't go into details, but his main angst, his main dilemma is, how do I make sure that my family gets taken care of after I'm dead? And he takes out a life insurance policy, etc. So if that person came to me, I would not think of them as a 35-year-old. It would help for me to think of them as an elderly, ailing person that is facing their own mortality and is consumed with worry. So, Eric Erickson talked about generativity versus stagnation, and then ego integration, and ego despair. And so, to someone like that, it might be useful to say, it's going to be okay. You're doing well. You have done well. You have set them up. It's going to be okay. They're going to be fine. Why don't we focus on what you need in the final days of your life? So as you can see, same character, same ages played, but very different approaches based on how old they are behaving. So next time you see someone and you're getting annoyed at them or having negative countertransference, think to yourself, how old are they behaving? And of course, you'd have to translate it to adult language, right? If you find, if one of your professor comes in and they're 60 years old and they're throwing a tantrum, you're not going to scold them, or say, "Oh, where's my sweet baby? There's something hurt you." No, you're going to get fired. But think about what that would look like language-wise, what you would say to someone like that, but actually is your boss. Again, guess where the origins of this is? I can't help detect this pattern. And I promise I'm not trying to sell the Gita. I get no kickbacks. And if you want to learn about defense mechanisms in much more great detail and more examples like this, and how you can use it in your practical life, here's my final shameless plug. I've developed a course for this too on Pangea. So, it threw a lot at you. We talked about countertransference, developmental arc, regression, the unconscious, etc. And the whole point, the whole goal of this conversation, of this webinar, is to just give you a little taste, a little appetizer, a little sampling of what it's like to think psychodynamically. And it has brought me so much joy and so much. I feel like I'm much better at every role I have, as a father, as a son, as a brother, as a friend, as a husband, as a psychiatrist, as a therapist, as a person standing in line at the bank, because I've been able to invest in thinking psychodynamically. So you're probably doing this already, but I'm hoping that this webinar actually helps you A, operationalize some of the stuff you're already doing, and B, whets your appetite and you're curious for more, because it certainly has brought so much joy to my life. Think about um, psychodynamics, like, I don't know if you've seen The Matrix, but if you have, this will help, where Keanu Reeves is in this world, which is actually made out of, it's actually a fictional world. It's made out of AI. It's all coding, it's numbers. And then when he gets enlightened at the end of the movie, when he realizes, when he gets evolves, he can see the matrix everywhere. He can see the binary instead of, so he can see past what other people can see. He can see what's invisible. So what I would like to posit is that the more you invest, the more you submit, the more you're a student about not just thinking about thinking, but also feeling about feelings, how you're feeling about your feelings, other people's feelings. And if you can remember that everyone has a past which is affecting their present, and it's a very big effect, and then you're practicing psychodynamics, and that will hopefully help you realize that the brain has its limits. If I wasn't a therapist, I would be bored out of my mind. When we think about it, psychiatrists, we have what, 75, 80 medications, and let's face it, most of the time when our patients come in, we kind of already know what we're going to do. We started them on sertraline, low dose. If they come back and they say, they're not having side effects, but it's not helping, we bump it up. If they say we're having side effects, we stop it. Right? So we already kind of know what to do, but the mind is infinite. So my hope for you is that the same thing happens to you that has happened to me, where I love practicing as a psychiatrist, as a physician, and it's because I get to meet not just the brain but also the mind. And the mind is the part that is so intriguing and so rewarding. I'll stop there. And if you have any questions or comments, or if you'd like to, if you're interested in more, that's the email. And I'm gonna request Dr. Divyam and Dr. Bhavya to put that in the in the description section also. And I'll pause for questions or comments.
That was amazing, Dr. Himanshu. You just simplified most of the terms, most of the concepts that we read in our residency, uh, and you, with the help of the Bollywood example.
I'm
So
glad that that's the whole point is to take these this unnecessary mysticism around many of these terms, right? So that's really what so many of my teachers help me understand it in very simple ways, and I'm trying to take forward. But
yeah,
you had a soul, yes? You had a question or a comment?
yeah, I have a couple of questions. So you just talked about the unconscious, and uh, so the unconscious is at play when we are consulting our patients. So how would you use uh, the awareness about the unconscious or the knowledge about unconscious in our day-to-day practice, and not just in the psychodynamic psychotherapy? If we are doing the OPD consultation for about 10 minutes or 15 minutes, would being aware of our unconscious and would being aware of the patient's unconscious, how would that help?
Absolutely. So, you're asking a very, very important question, right? So the simple answer is this, like what I talked about today was just an introduction to the concept of it, right? And then operationalizing it, learning the different techniques and the different ways that unconscious can intervene or interfere or help us, and what to do with it is an entire course in itself, right? And unfortunately, I don't think we can go into it completely. But what I will say to the audience members, the people that are watching this, is if you have any specific questions or any specific scenarios, feel free to put them in the chat, and I'll try my best to answer those either through chat or maybe quick video or something like that. But really, it depends on the very specific situation, and uh, what it needs is practice, practice, practice. Just like anything else, if you want to learn to play the guitar, the first time that you try to play a song, it'll be painful and it'll be clumsy and it'll take so long. But then if you keep practicing, you may reach a place where you're just seamlessly, at least, not always, I think that's impossible for someone to do it always, but seamlessly weaving your understanding of the unconscious into your conscious recommendations and reactions and responses, and the patients also. And it happened a lot more than if you were not even aware of that. But I wish I could go in more detail. But really, that's, I mean, that's what case consultations are for, right? So you talk about specific cases and say, okay, this is what I did. This is, so I'll give you an example. My analyst, the person who became my psychoanalyst, who analyzed me, was first my teacher. He was a professor at my institute, and I presented a case to him, right? And the case started this way: the patient comes in 10 minutes late for their 30-minute medication management, right? And they said, "I'm so sorry, I'm late," and I said, "That's okay. The important thing is you came." And we start the session. Now this guy stopped me right there. I had the whole session to present. He said, no, let's just wait here. Like, see what Dr. Agrawal has done here is he's shown his kindness and his patience. That's wonderful. And what he didn't do was he didn't explore it further. So it might have been useful to say, yeah, how does it feel to be late? or I've noticed that you're often late, right? I'm wondering if you can talk about that in a non-judgmental way. And now, 15 years later, I had a patient who came in late, for the fourth or fifth time, and all we did for the rest of the session was talk about their lateness, and it led to very useful insights for the patient. And they realized that they actually do this other places too, and it's related to reasons. And guess who stopped coming late?
Hmm.
So this is an example of me being aware that unconsciously something is happening, and to bring it into the frame. And it doesn't take that long. If you're, in a busy OPD, you could consider saying, I've noticed that you're often late, if it pertains, right? Um, uh, what I'd like you to do is please think about the fact that you're late. So you brought it from the unconscious to the conscious, and maybe consider why you're late. See, that is a very different approach than what can you do to not be late again? That's a more CBT approach. But if you just instill in them, I want you to think about it. Just when you go home, just think about it. Why am I late? And 8 out of 10 patients might not even think about it. But the two patients that do, you have started a spark within them. And they might come back and say, one of them might say, I know why I'm late every time. You remind me of my father. You have a beard like him, and I used to be very scared of him. Right? That's like golden. That's like a very, very amazing mind. And the other person might come and say, I thought about what you said. I still don't know why I'm late, but look, I'm on time today.
Yeah. That was an amazing insight, and I remembered one talk given by Dr. Salman Akhtar that he said that uh, Freud, we can divide Freud's work into three or four types. One was the developmental Freud, one was the clinical Freud, and one was metapsychological Freud. And he said that metapsychological Freud is, I think, the most useful.
Yes, exactly. I mean, of course, I agree with him. He's brilliant, but to me, psychodynamics is that meta part.
Yeah,
Psychodynamics, and especially applied psychodynamics in everyday life, whether you're a therapist or a psychiatrist or not, it's the concept of thinking about thinking.
yeah,
That is truly revolutionary. It can really change your life. And it doesn't take that much time. At first, it hurts, but after a while, it becomes pretty seamless.
yeah. And even during the formal psychodynamic psychotherapy, so whatever comes at you, you treat it as a material for analyzing. Am I right?
I treat it as material for observing.
Okay.
Right? So it's all, as they say, grist for the mill. But the word analyzing is actually a very specific, it involves very specific techniques and interventions, right? So when I meet someone at a party, right, and they say, oh, you're a psychoanalyst, so you're analyzing me. And I'm sure you must get that also at everywhere. It's like, oh, you're a psychiatrist, you're psychoanalyzing me, right? And I say, absolutely not. I'm absolutely not psychoanalyzing you because, first of all, you're not paying me. Why would I do this for free, right? If you're a plumber, then I'm not gonna meet you at a party and say, please fix my tap, right? Secondly, it takes so much to be able to start analyzing. You need so much material first, right? And so I would say, to answer your question, everything that's going around, the more you can be aware of, and the more you're curious about it. Everything that the patient does, you do, the diet that you make, the analytic third, as they say, what we're co-creating together, should be used for observation. And then some of it can be used for analysis. Does that help? Does that make sense?
Yeah. uh, you talked about psychodynamics, and with the chat with the talk we had yesterday uh, on difference between psychoanalysis and psychodynamics. Why don't you explain that for the benefit of the viewers? I mean, we have talked about that, but you can
You're
just.
right, in our meet and greet, yeah. Sure, I'd be happy to. So, the question you'd asked was, what's the difference between psychodynamics and psychoanalysis, right? So let me tell you a quick anecdote, which unfortunately sheds light on the state of psychoanalysts and analysis in USA at least. So this question was asked by the chair of an institute, and I won't say name names, but this was question was asked in front of me by someone that was very interested in psychodynamics and psychoanalytics, much like you, right? But did not have any formal training in it yet. And they said, "What is psychoanalysis?" And I kid you not, there were three seasoned psychoanalysts there. None of them could explain it, to the point where that person got frustrated. It's like, it's a pretty simple question, but we have failed at giving a pretty simple answer. So the answer I gave you is not perfect, or even like, might not even be accurate, but it's just how I understand it, how I've come, how over the last 20 years, how I've stumbled upon and put pieces together. So what I said to you yesterday, I'll repeat again, is that, we talked about what is psychodynamic, right? Those three fundamental things. Childhood matters. There's something called the unconscious, and let's use it. And then transference, countertransference, let's use it. Again, this is overtly simplistic, but now let's say a patient has decided that they want to engage in psychotherapy with you, right? By the way, you do psychotherapy with a patient, not at them, right? So you're doing psychotherapy with them. If they're sitting in front of you, you can see each other's face. They're coming in once a week. That's psychodynamic psychotherapy. If they're coming in once every 4 weeks, I don't know what that is. It's not therapy. That's just my opinion. Maybe it's a bit cheeky. But if they're coming at least once a week, it's psychotherapy, psychodynamic psychotherapy. Now, at any point, if we decide to go up on the frequency, and now we're seeing each other 2 times or 3 times a week or 4 times a week, but we're still sitting, face to face, and they can see me, I can see them, and they're sitting on a chair. That's called psychoanalytic psychotherapy. Or if at any point, even if we're meeting once a week, if they decide to take the couch, see, here's the infamous psychoanalytic couch, right? And so if they decide to lay down on there, and then I'm sitting behind them and they can't see me, right? Like the Freud caricatures, that also is psychoanalytic psychotherapy. But the only way, and I don't know why, but technically, it's called psychoanalysis if they're laying down, they can't see you, and if it's at least 4 times a week. So you start off with psychodynamic psychotherapy in the chair. You either take the couch or you increase the frequency, become psychoanalytic. And then at the moment it touches 4 times a week or more, and you can't see the analyst, that's called psychoanalysis. So it's really, of course, it leads to a very different meanings. There are different things and outcomes from both interventions. But fundamentally, I believe it is the differences of logistics, frequency, and position. And I'm sure there's a lot of people that would be outraged at what I just said about, no, that's not true. They're so different. Like, yeah, of course they're very different. But if you want to explain what psychoanalysis is, if someone is in psychoanalysis or not, technically those are the criteria that need to be.
Yeah.
And having said that, there's people that have not. There's so many people that have not made any use or any progress or benefits from psychoanalysis. 4 times a week, 5 times a week, laying down, and there's so many people that have received so much from once a week psychodynamic psychotherapy, right? So it's not a one size fits all. It really it's more about what's a better fit for you.
Yeah. We have next question coming in from Dr. Bhavya Bansali. So handing over to Bhavya.
Hi, Dr.
Yes.
Bhavya.
Hi, Dr. Himanshu. I would like to say that it was one of the best webinars that we have had up till now.
Oh wow! Thank you. Your check is in the mail.
Right. My question was that for someone who is beginning to practice psychodynamic psychotherapy, how important is the patient selection and what are the specifics of it?
Great question. So again, I more details in the course that I teach, but fundamentally, I'll say it in this way, and I hope it doesn't sound too cryptic or too vague. I believe that we don't select the patient for a therapy; the patient selects the therapy, right? So, and there's a technique. I'll try and answer it very quickly and kind of a abridged version. So, anytime someone comes to me and they say, "I would like to do psychotherapy," right? I say, okay. So there's two kinds of psychotherapy. And again, this is overtly simplistic, right? But I say there's two kinds of psychotherapy. Psychotherapy type one, we talk about the here and now. We talk about the relationship between feelings, thoughts, and behaviors. and it usually is very interactive, very hands-on, right? And you get homework, you do worksheets, and it really helps you in what's going on right now. And it doesn't take as much time. You can start seeing the results within weeks. Type 2 psychotherapy. Now, this is the kind of psychotherapy that takes longer, and there's more of a focus on childhood. Type 1 psychotherapy doesn't go too much into depth about childhood. Type 2 psychotherapy, you talk about your childhood and how your childhood experiences or your past experiences are affecting you now. And it not only helps you with what you can do better, it also helps you understand why you have not been doing it better. And so, and then I explain the unconscious, and then I explain countertransference and transference. And then I say, out of these two, type 1 and type 2, which seems more appealing to you? And I kid you not, Dr. Bhavya, I mean, I think 90% of my patients know immediately.
Right.
Immediately, they're like, oh, that one, type 1. I don't want this whole childhood nonsense. I want practical strategies right now. Or they might say, oh, you know what? Practical strategies would be good. And there's a lot of CBT and psychodynamic psychotherapy also. It's not like practical strategies are forbidden or supportive therapy is forbidden. They say, but I really want to get into the depths of my childhood and how it's affecting. So that's clue number one.
Right.
Clue number two, I always invite them back for a second consultation. So just for the initial visit, before we decide to do psychotherapy, there's two visits. And the second visit has many purposes. Again, more details, in a separate course. But the first thing I ask them when they come back for the second visit is, what did you think about our first meeting? And if someone says, oh, I didn't think much at all,
Right.
that's showing that they're not very psychological minded. So that might be a clue about whether they're a good fit for psychodynamics. It doesn't mean that they're ruled out. But if someone comes in and I say, did you think about our last session? It's like, oh my God, are you kidding me? I haven't stopped thinking about it. The moment I left, I thought, blah, 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 blah. And on the way drive home, I realized, oh my God, you know what? He's got a beard just like my father. I wonder if that's why I was sitting like this. And then I had a dream, and I don't know what that means, but I was excited and nervous about coming back here. Now that is psychological mindedness gold, right? That's the kind of person that will benefit a lot more from psychodynamic psychotherapy than person one. Person one can also benefit, but it'll take a lot more work. Does that make sense?
Yes. So really, it was a very helpful answer from you. Uh, Back to Dr. Divyam then.
Thank you.
Yeah. So, following up on Dr. Bhavya's question, so he sort of asked about who would be or how do you decide upon the type of therapy that the patient needs. So, you talked about the patient factors, but are there any disorders or specific disorders that would be treated better with one type of therapy than the other one?
You know, I had a very different answer for this 10 years ago, right? And this is my answer now. So of course there are some disorders that psychotherapy is less likely to work. Uh, Psychodynamic psychotherapy, I believe, can help everyone, but to what extent is different, right? And the use of it is different. If someone is severely manic, if they're very manic, if they're got bipolar and they're haven't slept and they're running around everywhere, so probably the only therapy that will help is supportive psychotherapy and maybe a little bit of CBT, right? It's very hard. But I can assure you, and I was so pleasantly surprised to discover this. I work in an inpatient unit right now in a hospital, and I see adults. And the last time I worked in a hospital was 10 or 15 years ago before my psychoanalytic training. But I have been so pleasantly surprised that my patients and I have been able to do psychodynamic psychotherapy when they're acutely psychotic. So I have had a patient recently that believed she was God. She didn't believe that God was talking to her. She believed she was God.
Oh,
And it was so rewarding that we were able to actually do psychodynamic psychotherapy as she thought she was God. So, with delusions, you don't agree with them, but you don't disagree with them. But we were actually able to, and I tried supportive psychotherapy, I tried CBT, didn't work. I use psychodynamic techniques. And she sat down and she opened up and she started talking about her life as a human in displacement, right? So I think that that has helped me really believe that there's no uh, disorder that is fundamentally you cannot. Of course, if someone is severely intellectually disabled, they're nonverbal, right? That might make it much harder, but I don't think it's impossible. Give it a try.
Uh, well, Dr. Himanshu, that came to me as a surprise because I've never heard of psychosis or mania being treated with psychodynamic psychotherapy. But uh,
Yeah,
what?
so it wasn't treated with psychodynamic psychotherapy, right? What
Yeah.
helped her was the medication.
Oh,
But psychodynamic psychotherapy was essential in order to get the patient convinced that medication would help,
okay.
right? So without that psychodynamic psychotherapy interventions, I don't think the patient would have agreed to take the medication. So the medication is what helped, right? I had another patient where she thought she was possessed by a spirit, actually a betal. She was a Caucasian woman that went to India on a retreat, and she said, I came back and the chudel, the betal, stuck onto me. Right? It was fascinating. And eventually, she agreed to take medication, but only after we had um, family sessions. By which I mean, I found myself doing kind of family psychotherapy. It was me, the patient, and her spirit in the room. And I couldn't hear the spirit, but I was doing things like, so when you said that, how did it make the spirit feel?
Hmm.
Oh, the spirit saying this. And so when he's saying that, can we like do some reasonable reality testing and say that's unreasonable? So I would have never thought about that before my exposure to psychodynamic psychotherapy, right? But that's tricky because you don't want to make the delusions worse. So that's the fine line of at no point at least as far as I know did I say that that's not real. So that as if part that comes from the unconscious. In the unconscious in dreams, there's no such thing as if, right? So everything is real. So I'm thinking it's as if this was real, the spirit, or it's as if the patient was God. But I don't have to say that out loud as long as I believe it, and as long as I don't make them feel like that I believe that this is real. Um, a lot more can be accomplished, and it was such growth for me to kind of venture into that space.
You know what? One argument against the use of psychodynamic psychotherapy is that it lacks evidence. And
Yes.
uh, most of the physicians, not just in psychiatry, but in all the other specialities all over the world, they follow something called the evidence based medicine. And since, you know, uh, you don't have much evidence for psychodynamic psychotherapy, so how would you answer this question if somebody asks you that it lacks evidence?
Yeah, I would say that's a very valid criticism, and it's about time that we started doing some studies. The psychodynamic community and psychoanalysts have been shameless and pathetic about doing research, and they've used all sorts of reasons why they didn't do research, right? But I've been saying this for the longest time. It is time to we can't call it a science. It's more of an art, right? We can't call it a science until we have more research, and that's why I call it a lifestyle. I refuse to call it a bona fide science. Most of the journals, the psychoanalytic journals, are not journals. They don't have any research studies. They are basically opinion pieces. So even Freud and his greatness and his theories that have helped millions of people, in the end, it's essentially an opinion piece. It's a case study. So we really need to come into the 20th century. Yeah, not 21st. We aren't even in the 20th century when it comes to evidence. So I would say you're absolutely right. We need to do a lot of research, and it needs to become evidence based. My hunch is it would be easy to do, and I'm trying to do my share, right? But changes will have to be made.
Uh, Dr. Himanshu, I'm loving this interaction. So, how much time do we have?
Yeah, actually, I have another seminar I have to teach. I'm teaching a seminar on dreams in about 5 minutes.
Okay, so I mean, do we have a space, or do you have time for one more question, or we
Of
should
course.
finish? Yeah. So, uh, again, I would ask that since you talked about most of the psychoanalytic journals being the opinion pieces, uh, I would even say that the therapy itself, it can be very, very subjective. Like
100%.
one psychoanalytic psychotherapist or psychodynamic psychotherapist is analyzing a particular thing or particular material as one kind of defense, and the other one would interpret as some other kind of defense. So, how would that work? I mean, we in science we tend to uh, we tend to follow standardization. So there's no standardization in psychodynamic psychotherapy. So how would you go about it?
It's a great question. Let me give you an analogy, right? So let's say you give 10 patients the same molecule. Use that word. I learned that word today. Let's say you give them olanzapine, right? Everyone will have a different response. Everyone will have different hesitation or buy-in. The meaning of taking olanzapine, what it means to take an antipsychotic, will be different for each one of those patients, right? But it's standard, and the outcomes will be different, and the side effect profile will be different. So how can we call this standard? Yet
It
we
is.
call it standard, right? Similarly, every single patient in psychotherapy will be different. In fact, we go to the extreme and we say in psychodynamic psychotherapy, the patient that you met yesterday or the last session, they have changed. And so have we, which is still not the same. So that's the dynamic part, right? So what it comes down to is I think we need to put a lot more emphasis and education on the standardization that does exist, but people don't know about it. People know about the CBT techniques because it's highly manualized and validated. I have seen it up front, but you have to like search for it, like the standardization, and that's why I wish to let as many people know, especially in India, about the standardization techniques that we use. But outcomes are variable, absolutely subjective. Here's what I will say: psychodynamic psychotherapy is a very imperfect science, and I'm using the word science now, right? And uh, I wrote this for an Indian journal, but it reminds me of the way that I can sum it up. And this is not probably a perfect answer, but it's the answer I've got. Is that I believe there are standard approaches to take. There are some rules to follow, but after that, it's like that song from by Geeta Dutt from like the 1950s, and I'll say it in Hindi, and I'll translate it. जाने क्या तूने कही, जाने क्या मैंने सुनी, बात कुछ बन ही गई. In other words, who knows what I said? Who knows what you heard? So this is the patient and the doctor and the therapist talking to each other, But somehow it worked out. So by that I don't mean like it's all just we'll just throw something and something work out. What I'm saying is I have no way to explain why it works. It works differently for different people, or I have some theories about how it could work. Like my analyst, when I asked him how does this work, he said, "I'm hoping something will happen between you and me that thank you, I've got a heart. Nice. Something will happen between you and me that you will find helpful, not just here but outside." Now that's an object relations uh, technique. An ego psychologist might say, "I'm hoping that over time we will uncover and explore the defenses you've been using and figure out which defenses are holding you back, which defenses are you should keep, and that will then translate to improvement in your life." Bottom line is this: good psychodynamic psychotherapy, you can only call it good psychodynamic psychotherapy if it makes real difference in the person's day-to-day lives, in their treatment goals, but also their life goals, right? Just like medication. But it would sure be a lot easier to explain if we actually had randomized double-blinded control trials for psychodynamic psychotherapy, right? And that's why I say to everyone that's listening, let's do it. And I think India might be well poised to do it. It's like, brilliant people in India who are jonesing and thirsty for doing this. So let's do it.
Sure.
Nice. Looks like you accepted the challenge. My work here is done.
One more question, Dr. Himanshu.
Oh, actually, you know what? I have to be a good psychoanalyst and stop
Okay.
because I don't want my other students to be. But please feel free to either put the question in the chat or just call me. We can keep talking. This is what we call ibtidai ishq. This is the start of our common love for psychodynamics, right?
Sure.
It's not the
Yeah.
all right. Take care.
So
Thank you.
thank you. Thank you very much
What a
for
privilege
your
this was.
time and experience.
My pleasure. And I've learned a lot today. See you around.
Yeah. Bye bye.